Dr. Golden, whose title I almost got right, is the medical director of the of Arkansas's Medicaid program and also a professor of medicine at the University of Arkansas.
Thank you, and I appreciate the invitation from ECRI and Dr. Lerner. Like a Cleveland Browns quarterback, I kept hitting send and didn't get a receiver, I think, so my bio didn't get out there. But so I have a degree in health policy from Brown, an independent major, a long time ago, and I've wandered around ever since. I've been board chair of the ACP, American Health Quality Association, the Medicaid Medical Director Network, served on the NQF board and in the LAN, and now I've been Medicaid medical director for about 9-10 years during an interesting period of time. Next slide. So Arkansas Medicaid has been interesting in that we had a journey that started in 2011. The governor said, let's do APMs, and said, go figure it out, and made it multi-payer. So while we were designing that, the first RFP came out for CMMI for implementation grants, so we were one of the first 6 that got implementation grants to put in place APMs. I have a slide, I joke, we were the non-Canadian recipient because everybody else was on the Canadian border. We actually launched episodes of care in July 2012 with the goal of changing the conversation about how you view healthcare, and I'll talk about that. And we launched a voluntary PCMH program in January 2014. To our surprise, we got 70% of Medicaid beneficiaries in a voluntary PCMH, and now we have over 85%, 190 practices, 900 primary care docs. It's really become an established ongoing approach to primary care in our state. Next slide. People, though, when I talk to different audiences nationally, internationally, they really don't want to know what we did, but how we did it, what it meant. And, we started out basically trying to get hearts and minds on the topic and promoted the idea that the healthcare system is unsustainable. That's not good for anybody, providers, patients, and that it needs to have a stewardship. And a stewardship has to be conjoint between payers, providers, patients, policymakers, I call them the 4 Ps. And that you want to be accountable for the patient journey, not just services, and get away from that. And if we accomplish nothing else in trying to bend the cost curve, just getting people to rethink what we pay for and what healthcare delivery is all about. So we started emphasizing that we wanted to incentivize metrics on total cost of care, outcomes, patient satisfaction, really population health. And there's an interesting sidebar on that as we've gone down this road. This has now put a tension between public health providers and payers, because in many ways, all of a sudden, public health has realized that the leverage points that payers have in terms of moving population health numbers is really now in the payer community, and it's really caused a bit of a tension. And we've seen it in different interesting public venues. And again, redefine rewarding success differently. And again, we're a rural, we were a kind of a blue, then purple, now a red state. And people bought the notion that the healthcare system is unsustainable, that we reward things in strange ways, we should reward things that don't get paid for. And one of the lessons also is who you pay for the performance can shape your results. So our initial episodes, we rewarded physicians. Some ACOs reward docs, some reward hospitals. Your approach to bed days varies depending on who's getting the reward. And you can get very interesting numbers on that. We did an episode on tonsillectomies. And the evidence shows that you can look at a tonsil, you can throw it away, you can give it to pathology. They're all correct. So we've now driven tonsils going to pathology from 75% to 25%. That's a cost savings for the system. Some of the pathologists were not happy. When you start designing value-based purchasing for oncology, there it's interesting because the beneficiary of the incentives are having to cannibalize their own revenue stream. Very interesting dynamic, very different. So, again, who gets the rewards and how the rewards get shaped are interesting. And we want to design it so that the incentives would promote local innovation. What works in rural southeast Arkansas will be different than works in Bentonville where they have Walmart. So, you want to have it flexible where people can use the resources and the workforce in their area to the benefits of what would work in their environment. And so it has implications for workforce. And I'm a big believer that all the debates between nurse practitioners and doctors, for example, is irrelevant when you put it into an APM. Because if independent nurse practitioners can work in an APM environment, more power to them. In the initial CPC environment, there was several hundred practices that got rewarded. I think there were only 3 or 4 independent APN practices. So people will start determining how much risk, what can they take on, how can they manage a population. And I think what we're seeing in our medical homes is that we're seeing docs and nurses and paraprofessionals redefining their roles within the practice to mutual satisfaction for professional satisfaction. It's very interesting in how it's playing with burnout. Next slide. So the essential elements we've had, we created a learning system. So as we went out and pushed people to think about new ways of delivering care, they pushed back. We had town hall meetings that would be attended by a couple hundred people on televideo or in person. And so we made it a two-way street. We put forward ideas, gave people data, they gave us back feedback. We wanted to reduce pain points, give them more data. I chaired the LAN on primary care. People hate EMRs. They hate check the box CPT codes. And the whole notion that maybe giving people upfront dollars and maybe a basic visit fee is very appealing because then you start documenting what's important to the patient and a health plan. And the notion that you break away from brick and mortar visits. You don't get paid right now in primary care unless the patient's in your office, which has all sorts of perverse incentives, both for the patient and for the doctor or the nurse practitioner. So these are kind of interesting things to do. We did multi-payer, and one of the pain points was to have uniform metrics, uniform reporting, uniform ways of getting data. Big data is critical as you do this. People want more data. As you give people data, they want more of it. We have a very good data analytic partner, both at our shop and at Blue Cross. They have their own shop. You don't want to put bad data on the street. That's the quickest way to put yourself into a very poorly perceived program. You want more real time if you can, but right now we have claims. You want to give people the patient journey, not just within their own system. That's the Achilles heel of ACOs. And people move, the metrics are clunky, and you have to go out there and verify what people say they're doing. So that, we just don't do attestation, but when we told people they had to have 24/7 live voice access in medical homes, we actually called the phone numbers and had to call people up and say, you're not doing what you said. Next slide. It's interesting also that when we put in a whole bunch of new transformation requirements for medical homes and gave them enough incentives to do it, we've only had to fire about a handful of practices, even in a rural state, because the incentives and the way of practicing were attractive enough that people actually went ahead and did it. I wouldn't have bet 25 cents 5 years ago that we would have had that much transformation. What are the barriers? Well, clinical metrics have been an unfulfilled promise. As an old NQF board, 12-step program person, it's been a great disappointment in life. I mentioned earlier this morning, quality metrics like Coors beer have just not panned out the way you think it was going to pan out. EHR deficiencies are really a huge barrier. I have speed dials now with ONC. My good friend in Oklahoma, David Kendrick, does groundbreaking work on this. Boy, different EHRs, even when you get them to extract data, transmit it differently, we are still way behind the curve on this, and this is a huge barrier. Who bears the cost? Our payers want to bear the cost more than the providers. And you want to start having data enterprises in states rather than different silos. So national payers have been a barrier. Sam. You know, we have been very blessed that we have a non-fragmented market, but, you know, it's very hard for United Healthcare or for Humana to come in to a one-of state and adopt our idiosyncrasies when they have a national cookie-cutter plan. I mean, it's just they have to reprogram and all sorts of things. Self-insureds have been laggards. We got Walmart involved, and Walmart could not get other self-insureds to come on board. And they are not interested in making the investments in the new incentives to transform how the system works. That's a problem. And, you know, the people game, we had an episode on ADHD, and, gee, we cured ADHD in the state of Arkansas. Suddenly everyone has ODD. So, you know, we have to go out there and monitor what people do. Fortunately, we haven't seen a lot of that, but the mental health industrial complex was very good at that. So, and then, of course, pharma. We, as Medicaid medical director now, I have had a new $500,000, $750,000 drug request on my desk for different drugs every week for the last 3 or 4 weeks. You know, what do you do with that? You can manage diabetes and asthma real well in one new drug, and you might as well. You know. So anyway, next slide. Are we there yet? Well, we're getting there. You know, we can make changes in a rural state. I think most providers, if you reward the better performers, APMs reward better providers for giving a more effective product with quality metrics and give them more money. What a novel idea. But you got to have, you have a concept, you have outreach, implementation, and you don't know how you're doing until you actually make payments. Because when you start making payments, then people will challenge your data. And you really don't know what kind of, how well your data is operating until you're actually putting dollars back and forth to the providers. So when I've had my colleagues in Tennessee and Ohio that have adopted what we've done, I say, until you make your payments, you don't rest on your laurels just because you think it's working and your episodes are running. Until you make payments, you really don't know where you are. So anyway, it's an interesting journey, and but it's going to be continued.
Thank you.